Hello, my name is Arif Khwaja and I'm one of the nephrologists at Sheffield Kidney Institute, and what I'm going to talk about in this presentation is give a quick overview of cardiovascular disease after kidney transplantation. So what are we going to talk about? We're going to talk about the impact of cardiovascular disease both on the patient and on graft outcomes. We're going to look at some of the evidence, limited evidence it has to be said, for how we should best manage cardiovascular disease after transplantation. And then finally I'm going to talk a little bit about new onset diabetes after transplantation, otherwise known as NODAT. So this is USRDS data really showing that cardiovascular disease is the leading cause of death with a functioning graft in the States, accounting for nearly a third of all deaths. And when you break down the USRDS data into the sort of causes of hospitalisation post-transplantation, causes of cardiac hospitalisation post-transplantation, you'll see that chronic heart failure, congestive cardiac failure and hypertension are much commoner than, say, an acute myocardial infarction. So they're at the top here, much commoner than sort of an acute myocardial infarction here. So perhaps a slightly different pattern of hospitalisation from the general population. So what is the risk of myocardial infarction after transplantation? Well, this is an analysis of sort of I think just over 50,000 patients. This is Medicare data from the States, looking at people who are active on the transplant list, and this is looking at the on the left-hand panel. You can see the cumulative incidence of acute myocardial infarction, but you can change that to sort of death or cardiovascular disease because the results will be the same. So in the black line here, after transplantation or after being waitlisted, for the patients on the waiting list, in the black line here, you get a steady increase in the number of myocardial infarctions. Okay, so these are people who are fit for transplantation but are waiting to receive their organ. Alternatively, if you look at those people who have been transplanted in the grey line here, these are deceased donor transplants, and you can see there's a significantly higher incidence of myocardial infarction between about 12 and 24 months, when the incidence starts to tail off a bit. And similarly, even if you've had a living donor, you are at increased risk of myocardial infarction, at least for the first 9 to 12 months, after which your risk starts to still rise, but is less than if you're on the waiting list, significantly less as if you're on the waiting list. So kidney transplantation in one sense is certainly life-saving, and certainly in the long term, after maybe 9 to 12 months with a living donor, perhaps a bit longer, with a deceased donor, your risks of myocardial infarction reduce, but in the short term, certainly for most of the first year or so, the risks will increase. And some of that will be related to kind of the stress around perioperative mortality. So you can see there's a very high spike here, there's a very high increment here in the instance of myocardial infarction. So that's all going to be related to higher risk of infarction after the operation. Okay, and this is data that was adapted from kind of Rob Foley's famous data looking at the risk of cardiovascular mortality in the sort of general population versus the hemodialysis population. And what you can see is that in the general population, of course, the risk of cardiovascular mortality just rises with age. In the hemodialysis population here in green, you see a much flatter line, so the risk of myocardial infarction, of cardiovascular death of an 80-year-old, of a 25 to 30-year-old on dialysis is broadly equal to somebody around the age of 80 who's not on dialysis. So that's a relatively flat line, but a much higher risk across all age groups, particularly amongst the young. And the blue line here is those people who've been transplanted, and you can see that the kidney transplantation probably attenuates the risk of cardiovascular mortality. So the risk doesn't return to that of the general population, but it's certainly significantly reduced compared to the dialysis population. And what about the impact of kidney function on post-transplant outcomes? So this is a post hoc analysis of the FAVORIT study, which is a study we'll talk about a little bit later, but this is a randomised control trial that looked at the effect of folic acid in renal transplant populations. And what you can see is that in this study, the risk of developing cardiovascular disease in black or dying in white was really related to your EGFR. Yeah, so the lower your EGFR, the higher the risk. Once you got to an EGFR about 45 and 50, things tended to plateau up, and there is this recurring suggestion in some of the data that maybe at higher EGFRs the outcomes may be worse again. That may be because higher EGFR reflects low, may just be a reflection of a low serum creatinine because of low body weight in certain people. Okay. And this is similar data. This is data from the PORT study. So the PORT study is a very large prospective study. It stands for the Patient Outcomes in Renal Transplantation Study, and it's a kind of prospective study that gathered data on a large cohort of transplant patients. And what you can see is that when you look at the 12-month EGFR, so 12 months after transplantation, you look at the EGFR and you look at the relative risk of death, you can see that there's the lower the EGFR, the higher the risk of death. So the EGFR improves, the risk of death plateaus at around 40 or so, and then there's some suggestion of an increase when the EGFR is very high. So again, this suggests that the lower EGFRs, you're at high risk of perhaps developing cardiovascular disease. So again, suggesting that kidney function per se may be important in the development of cardiovascular disease. So the next question is there anything that we can do to predict cardiovascular disease? And I think the first thing to say is that both the Framingham risk equation and biomarker, the Framingham risk equation performs relatively poorly in the transplant population, but there may be some utility in terms of biomarkers, in terms of predicting cardiovascular outcome. And I'll show you the data of that with regard to both those things in a second, but it's important to realise that predicting risk is different from being able to reduce risk. So you may be able to develop tools that can predict risk, but how that impacts on patient management is less clear. So if we look at sort of individual risk factors for cardiovascular disease after transplantation, again from the PORT study database, these were a whole range of risk factors that were identified, and some very traditional: smoking, dyslipidemia, diabetes, including, of course, no doubt, BMI, but obviously the impact of pre-transplant cardiovascular disease is important, GFR is important, dialysis vintage, and anemia may all contribute to cardiovascular risk. What about equations? So the PORT study then attempted to kind of develop a risk equation that incorporated a variety of risk factors, including pre-transplant diabetes, pre and post onset diabetes, pre and post transplant cardiovascular events, age, rejection, sex, duration of sort of time on dialysis, etc. So they took all these risk factors and tried to come up with an equation, and there was a suggestion that the equation actually predicted cardiac risk better, these two PORT equations here at the top, than a standard Framingham equation that's used to predict cardiovascular risk. And what about troponin? This was a nice study from the Mayo Clinic that just looked at pre-transplant cardiac troponins, and what you can see very clearly is that pre-transplant cardiac troponin correlates with poorer survival post-transplantation. And so if the troponin doesn't appear to normalise, that may associate with adverse events. So that's of course a way of identifying patients with increased risk. What you actually do about those patients with increased risk is less clear. So just to summarise, really, there are a number of risk factors for cardiovascular disease after transplantation. These can be divided into those risk factors that were present before transplantation, diabetes, smoking, time on dialysis, pre-existing vascular disease, age, and the impact of things that change after transplantation. So there may be the effect of immunosuppression on EGFR, on new onset diabetes, on lipids, high blood pressure, left ventricular hypertrophy. So all of those will combine to increase the risk of coronary disease and cardiac death. So let's just look very briefly at the impact of immunosuppressants on cardiovascular risk. Well, most immunosuppressants, as you'd expect, reduce the risk of rejection. The calcineurin inhibitors obviously reduce GFR, as you'd expect, but the calcineurin inhibitors and steroids all increase lipids, and they all increase, all increase blood pressure, they all increase lipids. Of course, the mTOR inhibitors, such as sirolimus, increase lipids significantly, and certainly steroids and the calcineurin inhibitors are associated with new onset diabetes. So the immunosuppressive medication themselves have got an adverse impact on cardiovascular risk. So how are we going to manage cardiovascular disease after transplantation? Well, really, we don't know how to manage cardiovascular disease after transplantation, but the mainstay of management is really as it would be in the general population, which would be to control hypertension, control lipids, think a little bit about immunosuppression, and obviously, very importantly, offer a lifestyle advice around exercise, smoking, weight, and using perhaps a diet. So lipids do rise after transplantation. So this is the ALERT study, which was a randomised control trial looking at the effect of Fluvastatin versus placebo. And if you look at the placebo arm here, you will see that lipids do rise. And again, that will reflect improved diet, and the patient's got functioning kidney, high risk of new onset diabetes, and of course, drugs as well. So what about statins and their impact on cardiac outcome? Well, this was really determined in the transplant population by the ALERT study. So the ALERT study was a randomised control trial looking at around 2012 renal transplant patients. The cholesterol at the time of entry could be anywhere between 4 and 9 millimoles per litre. Sorry, that's a typo. That should be between 4 and 9 millimoles per litre. And the primary endpoint were MACE, or major adverse cardiac events. And you can see that Fluvastatin here significantly in black, significantly reduced total cholesterol and significantly reduced LDL cholesterol. However, when you looked at the outcome, the combined primary endpoint, there was really no significant difference in primary endpoint between the Fluvastatin group and the placebo group. There was a small, statistically significant difference in myocardial infarctions, in cardiac death, and cardiac death or definite myocardial infarction. So it does reduce the risk. Statins were associated with reduced risk of cardiac death, but there's no reduction in overall mortality or cardiac intervention. So I guess what this trial tells you is that it probably is worthwhile taking statins in the sense that they reduce cardiac death. Well, it won't have any impact on overall mortality, and therefore it's a risk-benefit as to whether the patient can tolerate the medication clearly well or not. And if you look at the long-term studies, sorry, the slide is a bit blurred here, so this was an open-label extension of the ALERT study. You got some statistical significance and some statistical reduction in major adverse cardiac events in the Fluvastatin arm, but obviously that was the extension study, and it was an open label study. So I think that it's fair to say that lipids certainly impact on cardiovascular events. They may impact on total mortality, but the evidence isn't so good, and statins are clearly of benefit. But you would clearly need to sort of evaluate the use of statins on a patient-by-patient basis. And if you look at the different cardiac endpoints in more detail, you can see some benefit in terms of revascularization, in terms of cardiac death, in terms of non-fatal MI, no impact on fatal cardiovascular events or on non-cardiovascular events or on all-cause mortality. What about blood pressure? Well, blood pressure is very common after transplantation. There may be because patients often have pre-existing hypertension. Calcineurin inhibitors and steroids will promote hypertension. There's activation of the sympathetic nervous system, and there's obviously evidence of salt retention. There are lots of risk factors for hypertension. I'm not going to read them out, but they're there on the slide for you. And there is certainly observational data to indicate that hypertension is associated with adverse outcomes. So we talked earlier about the FAVORIT study, and if you look at that data from that study, something that would indicate that patients that had blood pressure greater than 140 systolic did have worse adverse outcomes. This is just observational data. And there's no randomised controlled trial to look at the impact of hypertensive interventions on cardiovascular events in renal transplant patients. Okay, so I'm just going to very briefly talk a little bit about calcineurin inhibitors because there's some nice data being published relatively recently looking at the mechanism by which calcineurin inhibitors can maybe cause hypertension, and it's clear that calcineurin inhibitors activate the renal sodium chloride cotransporter, and that leads to increased extracellular water, and that may explain why CNIs cause hypertension, because if you give CNIs to NCC knockout mice, you don't get any effect on blood pressure. Thiazide diuretics block the renal sodium chloride cotransporter, so it does make sense, if you like, for patients who are a little bit hyperkalemic and a little bit hypertensive post-transplantation with reasonable renal function to start off with a thiazide diuretic. What about ACE inhibitors and ARBs? Because obviously they're thought to be cardioprotective in the general population. And if you look at this nice review of the use of ACE inhibitors and ARBs from the Collaborative Transplant Study database, it really shows that there's no evidence that the rate of cardiovascular death in kidney transplant patients receiving ACEs and ARBs was any better than those not receiving ACEs or ARBs. So what do KDIGO say what we should do about the blood pressure? KDIGO say that the blood pressure target in adult transplant patients should be 130/80. That's a 2D recommendation, which means there's very little evidence to support it. They say that you should choose a blood pressure lowering medication taking into account the time after transplantation, use of calcineurin inhibitors, presence of albuminuria and other comorbid conditions. So basically, with regard to blood pressure, we don't know what the optimal target is or what the best therapy should be. Okay, this is probably one of the largest trials looking at cardiovascular outcomes in transplant patients, the FAVORIT study. This was a study where over 4,000 patients that were randomised to high dose or low dose folic acid combined with vitamin B6 and 12 supplements. And the idea was to lower homocysteine, that if you lowered homocysteine you can improve cardiovascular outcomes. And there was absolutely no effect of the high dose high dose folic acid and vitamins in reducing cardiovascular death. That's in panel A. No effect on all-cause mortality and no effect on kidney failure. This was despite the fact that the high-dose arm actually did reduce homocysteine, again implying that reducing homocysteine has no significant effect in isolation on cardiovascular death post-transplantation. Okay, finally I'm just going to talk about no doubt or new onset diabetes after transplantation. So first of all, one of the problems with the literature here is that people define no doubt in different ways. Some people say it's when you're on insulin, some people say it's when, some people have written in the literature every time someone starts an oral hypoglycemic. So that's one of the problems with the data. But really the diagnostic criteria are set out on this slide. Sorry, it's a typo there by me. That should read, I'll change that now, that should read diagnostic criteria, and you can see the criteria here. You require one of the three following: a random blood glucose greater than 11, fasting blood glucose greater than 7, or an oral glucose tolerance test with a plasma glucose of greater than 11.1. And then there's a separate definition, which I won't read out, which you can see on the screen there, for impaired fasting glucose and impaired glucose tolerance. Okay. So this slide summarises the modifiable and the non-modifiable risk factors for NODAT. You can see that obesity, metabolic syndrome, immunosuppressants such as tacrolimus in particular, steroids, rejection episodes, CMV, hepatitis C, beta blockers and thiazides are all potentially modifiable risk factors for NODAT. And then there are non-modifiable risk factors such as age, ethnicity, genetic predisposition, perhaps gender, probably polycystic kidney disease. Okay, so if we want to look at how immunosuppressants may cause hyperglycemia, I think in very simple terms, and this slide summarises it nicely and you can read that in closer detail, but steroids in general will promote insulin resistance. There may be sort of increased gluconeogenesis from the liver, reduced glycogen synthesis, increased lipolysis, increased central adiposity and visceral aspartosity, but essentially you're kind of increasing insulin resistance. Calcineurin inhibitors are probably directly toxic to the beta cells within the pancreas. They can reduce insulin gene expression, increase islet cell apoptosis and vacuolation. So they're really just causing insulin hyposecretion. Okay, and therefore the treatments will kind of vary depending on the degree of hypoglycemia. Okay, so what is the clinical significance of new onset diabetes? Well, there are different outcomes you can look at, but if we look at the outcomes with very strong evidence, there's very good evidence to show that NODAT correlates with, associates with high risk of death, high risk of graft failure, high risk of cardiovascular mortality. There's sort of weaker evidence to see whether NODAT correlates with development of nephropathy, and some moderate effect on infections and neuropathy. But on these key endpoints of mortality, graft failure and cardiovascular disease, NODAT has a very significant effect. And just to highlight that, this is a study from Norway looking at just over 1,400 patients without diabetes who underwent a glucose tolerance test at 10 weeks after transplantation, and again the median follow-up was 6.7 years, and what you can see is that the risk of mortality really is much higher in people with post-transplant diabetes, a little bit less in people with impaired glucose tolerance, and less with people with normal glucose tolerance or impaired fasting glucose. So post-transplant diabetes and impaired glucose tolerance are really associated with a higher risk of death post-transplantation. Okay, and this is further data, if you like, highlighting the adverse effect of NODAT. So this is data from the USRDS and Medicare looking at transplants between 1995 and 2002, and it's really data comparing the risk of NODAT to acute rejection and or the relative risk of NODAT and acute rejection. And what you can see, and on the left hand side here, is you've got the probability of death with a functioning graft. So this is death really on the left hand side, and in the purple and green line here is the risk of death for patients who had one episode of acute rejection or patients who've had no development of either no rejection or no new onset diabetes. So if you don't get rejection, so if If you have rejection on its own, it doesn't really impact that much on mortality and is not that different from no acute rejection or NODAT. However, if you develop NODAT, this is the red line here, there's a much lower chance of survival, the risk of survival, the survival rates are much lower, and if you develop NODAT in conjunction with acute rejection, the risk of survival is again lower, although not significantly different from NODAT alone. Again, implying that when it comes to overall death after transplantation, the risk is much higher with NODAT, and actually the risk of acute rejection on something like death is pretty marginal. So what about which calcineurin inhibitor is worse? Well, this is data from the Elite Symphony study, which is a randomised controlled trial, which I'm sure you've come across already, but this is a randomised controlled trial that compared different regimes of calcineurin inhibitors and sirolimus in conjunction with mycophenolate. And in this retrospective analysis, you found that the risk of NODAT was much higher in the group randomised to low dose tacrolimus when compared to low dose or standard dose cyclosporin. So there definitely is a signal that tacrolimus is probably associated with an increased risk of NODAT. And if you look at data from this randomised control trial, which is the DIRECT study, which stands for Diabetes Incidence After Renal Transplantation, this was a 6-month open label study. Patients were randomised to tacrolimus or cyclosporin. The primary endpoint was NODAT or impaired fasting glucose, as defined by using a sort of a glucose tolerance test. What you found was that tacrolimus was associated with a much higher risk of new onset diabetes. So tacrolimus is a problem, and tacrolimus is associated with a higher risk of diabetes. Okay, so just to summarise, I'm just going to say, well, what did I say? I said cardiovascular disease is the commonest cause of mortality post-transplantation. Cardiovascular disease post-transplantation may be qualitatively different from cardiovascular disease in the general population. I think statins certainly have a modest effect on cardiac death post-transplantation, although not on overall survival. And there are clearly multiple risk factors which I've shown you, including GFR, which mean that any single intervention is unlikely to have an impact on cardiovascular mortality. And obviously you need to think about that when you're designing, when one's designing clinical trials. Amazingly, we still don't know what the optimal blood pressure should be for people who are hypertensive, nor what the best drug should be for hypertensive patients with hypertensive transplant patients. NODAT is a major predictor of adverse cardio events, and therefore it needs to be treated seriously and is a sort of real cause for concern. And certainly tacrolimus is much more diabetogenic than cyclosporin. And finally, pre-transplant cardiovascular disease is a major predictor of post-transplant outcomes, although transplantation does seem to attenuate that risk. Thank you very much for your attention.